For patients presenting with low back pain and leg pain, that is referral of symptoms either down the back or the front of the leg, we need to consider including a neurological assessment. The assessment starts the same, looking at the patient's posture. We then look at the range of movement, considering range, quality and response to the symptoms. So if we can bend forwards, so we're first assessing the flexion and the patient's willingness to move and any response to the pain. We then ask the patient to extend, again looking for the quality of the movement and any symptoms. And finally looking at the patient in right side flexion, again looking for the quality of the movement, and then left side flexion, and again any response to pain. Sometimes useful to look at the patient's reaction on the face also in terms of pain response. Whilst in standing, you can commence the start of the neurological assessment with a quick test of the myotomes. Initially S1, asking the patient to go up and down on the toes, repeating standing on one leg, looking for the movement and any pain inhibition and repeating on the other leg. We then ask the patient to heel walk, which is a test of the L5, again looking for any weakness, particularly in the dorsiflexion. We then ask the patient to take a seat on the plinth, and we check the reflexes in sitting. The patella reflex, looking for symmetry, and then the tendo Achilles. Continue with the neurological assessment. We ask the patient to lie down on the back. And in lying, we start with the straight leg raise. If this is the symptomatic side, look for the range of movement, the response to pain, and any increase in low back or leg pain. Whilst in this position, we can check for any underlying hip pathology, taking the hip into flexion and then medial rotation. Also, while they're in this position, we can commence the test for the myotomes, testing for any hip flexion weakness. So if you get the patient to hold the leg in this position. Continuing the myotomal assessment, ask the patient to hold the leg there and don't let you move it. We then continue this on the other side, repeating the straight leg raise, and again looking if it's the symptomatic side for any response to pain and the range of movement. Checking for any underlying hip pathology, taking the hip into flexion and medial rotation, and looking for any increase in buttock or groin pain. And whilst the patient's still in this position, resisting hip flexion is testing the myotomes. We continue to test the myotomes by resisting knee extension. And then we continue testing myotomes of both legs, asking the patient to hold the dorsiflexion and applying resistance, asking the patient to hold the great toe in a dorsiflex position whilst you resist them, asking the patient to hold the foot in that position in eversion while you attempt to invert the foot, and then ask the patient to push you away, plantar flexion, again applying resistance, looking for equal amounts of power in both limbs. And finally, we then resist the hamstrings, knee flexion, and we repeat that on the other leg. Again, looking for symmetry and any areas of weakness. For those patients considering vascular components, palpate for the pulses, both dorsalis pedis and the posterior tibial. And whilst testing for this, look at the coloration in the feet and the quality of the skin condition. And testing for Babinski if there's consideration of any upper motor neuron component. And the same on the other foot. And finally, to complete the neurological assessment, testing for sensation, looking for symmetry in both legs and that both legs have the same sensation. If there's any areas of paresthesia or numbness, then focus on the specific areas more closely to ensure that there is full sensation. We finally complete the assessment by asking the patient to turn onto the front. And for those patients with symptoms referring down the anterior aspect of the leg, we perform prone knee bend, again looking for range of movement and any response to pain. And repeating that on the other leg. And finally, palpating the lumbar spine, looking for any areas of local tenderness, pain and hypersensitivity. And that completes the assessment for patients presenting with low back pain and leg pain.